Hi, it's Dr. Noel Robert Williams from Oklahoma City, Oklahoma, Optimal Health Associates. COVID-19 update, April 27, 2020. I'm going to talk a little bit and then I'm going to answer some questions because you have your FAQs I get all the time. So the first thing, about just shy of 1 million cases in the United States, 56,000 deaths, world 3 million, about 210,000 deaths roughly. Oklahoma, there wasn't really any changes today in our statistics. And as I've talked about, the statistics in Oklahoma are very difficult to ever understand because we have had very poor testing in terms of quality and quantity. So again, very hard to know. So we're testing the sickest of the sickest. So let's talk about something that I have some questions I'm going to answer here eventually. But let's talk about death rate changes. The death rate's gone up a little bit in the United States, and we'll continue to see that. And there are several reasons. One is, since our volume of testing is relatively low, we aren't going to test the number of people that we really would want to in order to see the true denominator, or the bottom of the fraction, versus the numerator, which is on top. So since our denominator is smaller, the numerator is more important in terms of impact. And so the thing is, we're testing the sicker people, or the sickest of the sick. And so it's kind of like a streetlight effect, as another doctor put it that I read, where the light's shining down, but it's going to pick out the very closest evaluable things. And so that's the sickest people. So our rate is 7.6% right now. In the end, it will probably be much lower than 2 or maybe even 1%. But since it's such an infectious disease, it's important. The other thing to keep in mind is the death rates are going to keep on going for a while, even though the surge seems to be abating for now. So why is that? So the normal course for people who die of COVID, and this is not 100%, this is a majority, and we'll talk about the subgroup in a second, they get first ill, then they get problems breathing, then they get pneumonitis, or a superficial infection in the lungs, then pneumonia, then they get more hypoxic. And that's usually about a 2-week process to get there, and then they get admitted, and then they go into different treatment plans or schemes. And eventually, as you start with maybe 20 people getting sick to the point where they're needing to be more evaluated, probably about half of that are going to go, or slightly less are going to get it, or slightly more are going to get admitted to the hospital. And then of that group, roughly that final half of them will end up dying. So if you start with about 20 people are sick, 10 or 12 get in the hospital, 5 of that group are going to die. And that final process takes about 2 weeks. So most of the deaths that are occurring this week, those illnesses started 3.5 weeks ago or so. And so even though the curve is flattening, the death rate is going to stay the same for a while, and then it will start to fall. There's another subgroup of people who die of COVID, which are the people who get sudden cardiac decompensation. And so those patients can actually die within just 2 or 3 days of symptom onset, or pretty immediately, but that thankfully is a rare group. Likewise, when people ask about are deaths being mislabeled, and I think that's, to an extent, way overblown by certain groups. Hospitals are pretty good at telling who's COVID, and the doctors, COVID patients present a very certain way, and so they do get tested. Flu patients present in a different way. Influenza patients are not the same presentation as COVID patients usually, so there's some differentiation, and especially now as the flu season's essentially over, we're seeing the people who get diagnosed are getting diagnosed accurately. And then when you look at death rates, one of the ways they're looking at this is, of course, just population norms. If you're in, state A, let's say Nebraska, and they look at over the last 20 years, 15,000 people died in the state in the month of March every year for the last 15 or 20, 25 years, and then all of a sudden it's 20,000 this year. Yeah, that could be just an outlier. But if it then goes back, probably some of those were from COVID. And that's what we're seeing in these regions, but be that as it may. So now I'm going to go on to questions that people have asked about. First was, why so political? I'm not political. I'm observational. Politicians make policy which affects all of us. And in my perfect world, and I think most of our perfect worlds, they would base that on rational decisions for the good of all of us and not the good of a few, and they would listen to scientists or people who are experts. And so when I've been criticizing in particular lately Governor Stitt, I know he has not been listening. I have personal knowledge and information from people who've told me he doesn't listen to us. He doesn't tell us what he's thinking. He agrees to things. So and then doesn't do them. So I'm just relating what I'm getting told by first people. And so that's all that I'm doing with Governor Stitt. Whether you agree with him or disagree with him, it's just what I'm going to observe because I disagree with some of the decisions he's making. I don't disagree with opening up, getting things rolling in the state now, because I think we need to get to a new norm. And the new norm is living with COVID by adjusting, wearing masks, washing our hands, taking supplements, those types of things. But that's why I sometimes go into politics, but it's observational about what people are supposed to be doing. So what's the next question? Long-term effects of COVID after recovery. It's looking, the number one thing is the recovery is a little longer in sick people, people who get really ill than in most things. It's probably a good solid month if they're hospitalized or get into intensive care situations, maybe even a little longer. People that have gotten just sick with COVID, it usually is a 2 to 3 week convalescence, not as long and not as bad. Long-term lung damage definitely seems to be occurring in the very sick people where they're losing a third to half of their lung respiratory capacity. That's going to be fleshed out more, but there's going to be a lot of side effects to that, the lung damage, and then if they have any organ damage from the hypoxia, where they had little emboli or strokes that hit things, and so that's going to be a case-by-case basis, but there's going to be a lot of people with effects from the COVID that we're going to have to deal with. Immunity from one strand of COVID to the next, that will vary. If we go with the best data right now, which is there's 30 different antigenetic variants on the protein spike, figure some of, and that's a 12% difference on the protein spike from SARS-1. COVID is SARS-2. So think some of those are going to be cross-reactive. I don't think you have to get all 30 strains to be immune, but you're going to have to get a variety of them to develop immunity. Just getting one infection isn't going to make you immune from the others. Now, if you had a more significant infection, maybe that's going to be more protective against more significance, but we definitely are concerned that if you have mild infections or asymptomatic infections, those aren't going to be giving you much immunity at all. But that data will flesh out, but it really makes vaccine development very, very challenging and antibody shot development very, very challenging if there's massive mutation on the most infectious part. So that's something we'll have to see and deal with. Antibody tests. Antibody tests are a waste of time. Several of my providers that work with me had asked, and they're my PAs and nurse practitioners, have asked if we can order them since they're available. And we have a rule officially in my practice: you cannot order them, because what do they mean? Tell me what they mean. I ask them, my staff, and they don't know either. I mean, they don't tell us anything of clinical significance except the person was exposed to a coronavirus, potentially a COVID-19. We don't know if it gives immunity or it doesn't give immunity. We have no idea. They have no role to play. They're experimental only. That is consistently the data. So you can go get one, but if it comes back positive, you're not protected. If it comes back negative, you are absolutely not protected. But again, we don't even know if the positives mean it was corona or COVID, and then we don't know how many strains they're going to be infectious. So again, not good use of resources. Does obesity factor into outcome? Obesity does factor into outcome, because if you think first, more mass, more little blood vessels, lower oxygen content definitely affects people who are obese more than people who are skinny. Number two, their bodies usually have more strain, the cardiovascular system does, so their ability to resist is going to be lower on a cardiovascular level. Third, some patients with obesity, and it's a substantial number, have some apnea issues. Apnea raises your blood count, the amount of hemoglobin and hematocrit, or your red blood cell count, and there's an association with it being more dangerous if you get a COVID infection, if you have any level of erythrocytosis or increased red blood cells, or polycythemia. So you want to really consider obese patients at a higher risk. They have blood sugar problems. So obese patients are definitely not in an optimal situation if they get COVID. So those are all the main clinical questions. A couple on supplements. I'm going to post something on melatonin tonight. Just a journal article summarizing melatonin's effects for COVID-19. It's a really nice article. I'll include the link so if someone's really detailed, they can read the entire article. But the bottom line, melatonin 1 to 2 milligrams for children or adults is plenty. Kids already have a lot of melatonin, so I don't think it's super important to add melatonin to children, but it's totally safe to add a milligram. Zinc, again, very important, 50 milligrams a day. If you can tolerate it, 30 milligrams if you can't, and take it with food. If it's someone under 100 pounds, probably about 15 milligrams or so. If they're under 50 pounds, probably 15 milligrams every other day. If it's someone between 100 and 125, probably 30. But remember, if you're getting 30 milligrams of zinc in because it doesn't upset your stomach and 50 does, it's fine. You're ratcheting up your immune system and making your alpha interferon functional. And alpha interferon is the only thing that was shown in a Chinese study that was helpful for sick kids. Everything else made them worse. So again, it's all about alpha interferon levels. Then if you've been on zinc now for a couple months, you've started at the beginning, you can drop a dose a week. I think you can skip one a week. You're not going to have any impact by dropping a dose. But again, if you're using the zincs that we carry, they're all in a capsule form and have a little bit different absorptive profile and safety profile than some of the less expensive zincs that are in tablets. But if you've been on it, once you've been on it a couple months, you can drop a dose a week. It's fine. You also want to be on a multivitamin, and you want to be on vitamin C. The other thing I would encourage people who are in dealing with lots of customers, you may want to start sucking on zinc tablets. There's Zicam. There's some other ones that are more like a candy that you can suck on, and those usually are 2 to 5 milligrams, and if you just suck on those through the day, that's going to keep the mucosal surface pretty antiviral.
So wait, on the zinc, if
yes.
you're taking 50 milligrams, can you still
you can
suck
still
on the zinc while
you can still
take a multivitamin?
Yes, you can. You maybe want to drop 2 zinc a week for theoretical concerns, but I sucked on zinc lozenges all day today, and that's what I'm trying to get in the habit of doing and getting my team to get in the habit of doing, because even though we're wearing masks, adding the zinc on the mucosal surface is very helpful. So that's the current thought process of what we're doing. We just need to get back to normalization. We need to start engaging carefully in public spaces. I think that's totally reasonable now. But again, my version of reasonable includes a mask, washing your hands a ton, and being on zinc and natural immunomodulators like vitamins, vitamin C, vitamin D, and your immune system's going to fight off most things for you. We'll start talking later in the week about what to expect in the fall, some theories on it, on the second wave, and what we need to be concerned about. Anyway, take care and good night.